Welcome everyone to today's webinar. This is Dr. Stephen Fletcher. I'm a pediatric neurosurgeon at the University of Texas Medical School at Houston and at Children's Memorial Hermann Hospital here in Houston. As we begin to start, we've got a few more people coming into the program, but welcome. This topic today is put together because of the continuing need that we as pediatric neurosurgeons see as our patients begin to transition into the adult years, and the concerns a lot of parents have and patients about the access to care. And so hopefully today we'll be able to present some things that you need to consider as a parent or patient in planning for the future with your particular needs in regards to either a neurologic but mainly neurosurgical condition. I would assume, and I'll go through these slides pretty rapidly, but as most of you have probably encountered by the very fact of dealing with your children with a neurosurgical problem or a neurologic condition, there's a lot of stumbling blocks to that care at times. Some of these are insurance related, as I've got in this slide. Some are just access to care. If you live in a big city like Houston, that's probably not a big issue. But if for those of you that live in a small town and have to travel to big towns, sometimes it's the situation where you're used to your team of doctors you've had for a decade, and then all of a sudden you find out that maybe they're going to retire, or there's a cutoff age limit which is practical for them to continue to take care of your child or you yourself. And then we have insurance issues to deal with. So I thought I'd cover quite a few scenarios. This is not an all-inclusive list, but sort of the main things that we see as neurosurgeons. And I'll kind of cruise through these slides. You'll have access to this program to review it in more detail. And we'll try to answer questions at the end of the presentation. But if something comes up that strikes me as particular that I need to stop, I may stop and comment on that as we go. I've covered these categories of disease that we see frequently as neurosurgeons: brain tumors, infection problems, craniofacial problems, spina bifida and hydrocephalus, which are big topics. The problem with head injury, especially the mild to moderate head injury patients with vascular disease, which is a little bit less common, congenital malformations of brain development that are peculiar to neurosurgeons, the ever complex problem of dealing with a child that's premature and has a lot of associated issues. But also the last thing, what we used to think was rare is often common. And as you know, if we look back at a decade in the past, heart problems in children that these kids usually died from at an early age are being fixed by our heart surgeon colleagues. A lot of neurosurgical conditions coexist with many other diseases. So as groups of doctors in creation of teams of care, we see better survival in a lot of these patients, and actually better quality of life in many of these patients. And we take for granted sometimes that our team is used to dealing with this on a daily basis, but once you become 25 years old, you have a situation where you may encounter family physicians or internal medicine specialists that aren't quite familiar with this. So you, the patient and parent, need to be proactive in helping in this continuity of care, and that's some of the things that we'll talk about today. we take for granted that our kid who's 10 or 12 years old, in a few years, if he's doing okay, may need to address the issues of driving. And every state has their own restrictions on who can drive, and this is just a consideration. And sometimes it's a sort of a pain to get a doctor to review a patient's chart and sign off on the safety of that person driving a car. Many patients have neurologic conditions that they're doing fine for years, and all of a sudden they have a seizure. Kids that have had problems in the hospital that may need continued care of their feeding tubes. It's nice to have your pediatric nurse that comes to the house and deals with this all the time, but what happens when they become 17, 18 years old? Are you going to be able to find a home health care specialist in your particular area that are competent in doing this, as good as the people that dealt with it when your child was a 1 year old? Good pulmonary care is always an issue for some of the patients that have a multi-system disease, and again, the transition to not only pulmonologists but respiratory therapists that are competent and well versed in these things can be difficult. You can't expect a same dose of a seizure drug for a 18-year-old as when they were 6 years old, so you have to be aware of these things. A lot of our kids have problems. They look different. They're in wheelchairs. They're different than the rest of the kids, and certainly in the media lately, we've seen all these issues, kids bullying one another, and those things don't just go away as they get older. So we have to worry about some of our kids that can't protect themselves being victims of a variety of social issues. Don't forget that an 8-year-old is going to become a 14-year-old and a teenager, and hormonal issues are going to becoming important for the females as well as the males. As time goes on, that craniotomy that your child had, or brain surgery, or whatever spine surgery that took place at 3 years of age, it's easy to forget exactly the technical details of what happened. And many of our patients have devices in their brains. They have devices on the skull, and just need to be aware of this. We'll cover that in a little bit. So that becomes important when you go to a new hospital, or let's say you move out of state and access health care. One of the things whenever you go get an MRI scan at a new hospital is, do you have any metal in your head? Do you have a shunt that's a programmable shunt? And for those of you that are dealing with hydrocephalus, you know what I'm talking about. Some of the others don't understand that, but these are all issues of knowing your health care that's been provided in the past. A lot of time, this next slide, the surgical defect, a lot of times as we get older, the surgery that we had, there are changes, dynamic changes that occur in our body, especially at the operative site. Sometimes a scar will change, but often if you've had brain surgery, sometimes there's resorption of some of the bone, and the little holes that we put in the skull sometimes will sink in, and often these are suddenly discovered, and sometimes can be a cause of concern. Sometimes there are things that subtle neurological findings on exam that may have not necessarily been recognized by your previous doctors, and you go see a new doctor and they pick up on these, and it's often confusing as to what is a new problem or what was a chronic problem. And often these things need to be addressed, and often a reevaluation of the patient's condition needs to be considered. So for brain tumors, patients with a brain tumor, as you know, if you have a brain tumor that's a benign tumor as a child, more than likely your outcome is going to be great. And this doesn't mean that the tumor can't recur. And so every hospital, every oncology center, every neurosurgeon has their variances in the follow-up. But for for the most part, I think most surgeons would agree, and most doctors taking care of tumor patients would like to see that patient on a periodic basis. If it's a benign tumor and it was resected and follow-up care has shown that the tumor has not recurred, still doesn't mean that you can just disregard that. And any time that you have a benign tumor that you've gone a long while for years and not had a problem, the new onset of a problem, say a seizure or headaches, probably ought to be a concern that not so much that your tumor has come back, but at least that you need to get in to see a neuro specialist, so to speak, and let them assess you and see if there's a concern that you need another MRI scan. Late onset of seizures can occur in patients that have otherwise not had seizures, and this is something that probably needs to be addressed. At a late date but unusual is the brain tumor patient that sometimes will develop headaches due to other causes, and we know that patients have brain tumors. Headache is one of the primary reasons they come to see a doctor, and is the reason for them having their diagnosis. And a 2-year-old that has a headache, or a 2 or 3-year-old kid that had a headache and underwent a craniotomy for a brain tumor resection, and they've been doing well for 10 years, and all of a sudden at age 14 their headache recurs. That's probably something to investigate, but don't forget that that could be a migraine headache or just the usual headache of that teenagers get sometimes. So again, having somebody to go to is an important aspect of continued care. Any patient that has had a previous infection as a child, we'll skim over this pretty quick. Probably it's more of an awareness thing than anything. If you have meningitis or a brain abscess or some type of infection in the head or spine, more than likely, if you've undergone surgical management or major medical management for that problem, the fact that it was cured probably means you truly are cured. But the reason I throw this in here just for completeness is anytime something sounds suspicious and you had a big infection in your nervous system, it probably is something to keep in the back of your mind, that you might ought to seek care for it again, just to make sure it hadn't come back. The biggest problem that we worry about is patients with shunts. If you had a shunt infection and you've been doing well for 5 or 6 years, then all of a sudden a shunt infection issue comes up again, that's probably cause to at least have a neurosurgeon involved yet again. Some neurosurgery patients have devices that have been put in their head, plates, again, shunts or other type of implants, and it's rare for these to be infected. But again, if that question arises, I think it's probably mandatory that a neurosurgeon at least be involved again, whether it's your primary neurosurgeon that took care of you in the past or a new neurosurgeon, at least for completeness. Those patients that have undergone craniofacial surgeries for craniosynostosis or some of the other more complex syndromal issues such as Cruzon disease probably deserve to have a long-term follow-up with their craniofacial surgeon and neurosurgeon. This usually, for our group, is at least a 5-year follow-up, and sometimes longer if there are other associated issues. Just be aware that as we continue to make new discoveries, the disease classification or the syndromal classification that you may have been categorized into could change. Those patients with Cruzon disease or patients with Down syndrome, we know that there are other associated organ systems that are involved, and as genetics becomes better and better, the recognition that another system is involved is extremely important, often to try and prevent and circumvent problems that can arise with these conditions. One of the most common things that we as neurosurgeons encounter is the patient with spina bifida. We have a huge spina bifida program at our hospital. These patients are at least patients that we see from day one to the teenage years. We often in our group will continue to see our spina bifida patients into their 20s, but as time goes on and practices have more and more patients, it's not practical for a pediatric neurosurgeon to continue to follow a spina bifida patient into the 30s and 40s. So this is probably one of the more important slides that are in this presentation. It's extremely important to understand that as a parent or a patient with spina bifida that you, especially if you have a shunt, worry about your shunt. You don't have to, you need to worry about your shunt should that situation arise. Patients don't usually outgrow their need for a shunt, and patients with spina bifida and have with a Chiari-2 malformation, if they begin having problems, it's important to recognize that you need to make sure that you're not having a shunt malfunction. Spina bifida patients, tethered cord syndrome or recurrent tethered cord is a big time problem. Those patients that have been stable for years and then all of a sudden start having problems with their legs or new onset of bladder or bowel changes need to be reassessed. And it's important to find neurosurgeons, especially adult neurosurgeons, that are willing to reassess the tethered cord. We work quite closely with our adult colleagues, adult neurosurgeons sometimes in this particular entity. As pediatric neurosurgeons, we're quite familiar with this, but as the patient gets older, a team approach with an adult neurosurgeon or adult orthopedic spine surgeon and neurosurgeon makes for better patient care. Progressive scoliosis, most of you spina bifida patients recognize that, and parents are especially cognizant of the fact that that needs to be monitored. Any development of a new neurologic deficit in a spina bifida patient, especially peripherally, is an indication to worry about the development of syringomyelia. And this requires not only a neurologist, but a neurosurgeon to be involved, and definitely mandates repeat imaging. Along with the spina bifida patient is the concomitant problem with hydrocephalus. Some shunted hydrocephalic patients, as they get older, if their shunt quits working, keep in mind that there are newer, not so much newer, but better results with endoscopic management of hydrocephalus. This involves placement of a device in the brain where we can actually create a small opening in the ventricular system to reroute the spinal fluid and avoid a shunt. So, for example, if your patient has a shunt and that shunt quits working, there may be an opportunity to consider an endoscopic procedure as a management of the hydrocephalus rather than a shunt revision or shunt replacement. As we all know, shunts break as you get to be 20 and 30 years old. Just because you're older doesn't mean that you're not going to have a shunt breakage or shunt get clogged up. Even if you're older, shunts can still get infected. But basically, as a rule, the longer interval you go without a shunt without a shunt problem, it's less likely that you're going to have a shunt problem. As we get older, those patients, those of you that have ventricular peritoneal shunts or shunts that go into the belly, if something happens to the abdomen, be aware that that may not be a particular place where fluid can drain anymore, and sometimes those shunts have to be converted to the vascular system or into the chest. The concept that we outgrow our hydrocephalus is one that needs to be thought out in a lot of detail. It's imperative that if you have hydrocephalus, and especially shunted hydrocephalus, that you, the patient, or the parent and patient, have a good understanding of what type of hydrocephalus is present And it'd be a good idea to keep the medical records of the doctors that treated you. It's very important to know what kind of shunt that you have. And I usually try to have my patients, if they're coming from elsewhere, coming from another hospital or coming from out of state or out of the country, whatever, to try and get their imaging studies so that we can review those. And it helps us make rational decisions about shunt care. Um, we have at our hospital here at Memorial Hermann a shunt hydrocephalus group that meets every month, and being involved in organizations like this, especially on a local basis, certainly is a good thing to help prevent problems in the future, especially as you transition to adulthood. Uh, let's not forget also that your 4-year-old with a shunt is going to be your teenager with a shunt. And a lot of these kids want to participate in sports and other activities. And that's extremely important decision. We hate to restrict kids from anything, but there's some practical aspects to this. And the decision to let shunted patients participate in at-risk sports is a big decision. Head injury sports that include soccer and football, boxing, that's something that personally I as a neurosurgeon don't allow, but I usually tell a lot of parents to put a golf club in their hands or get them into swimming or something else. But head injury sports, in my opinion, in the shunted patient is something that puts them at big risk. It's dangerous, I think, to assume that a patient has outgrown his hydrocephalus, his or her hydrocephalus. That we do know that that occurs sometimes, that patients are no longer shunt dependent. However, in a patient who has a broken shunt and is doing okay, I think it's not reasonable to assume that the patient is shunt free. Therefore, if the situation ever arises where you, the parent or child or patient, has been told that you no longer need your shunt, I would probably at least seek the care of a neurosurgeon who has an interest in hydrocephalus. I think anybody that has been told that they need to not worry about being shunt dependent anymore, they need at least an MRI scan to look for certain findings on the MRI scan. In our particular practice, we usually try to take advantage of our ophthalmology colleagues and reassess the patient, do a good history and physical exam on them. And then there are other tests. Sometimes they'll give us a clue whether somebody no longer needs their shunt. Again, the reason to try and keep as much of your imaging studies on a CD in a safe place for future reference. By virtue of our hospital, we are probably one of the largest head injury centers in the country for adults and pediatrics. Fortunately, most patients with a head injury are mild head injury patients, and there are very few sequelae that occur. However, with patients that have had bad concussive injuries or been in a coma for a while and have survived a severe head injury, there are a lot of things that we need to worry about. Those patients that go on to needing rehab, once they graduate from rehab, that's not the end of the story. So a pediatric head injury patient who has graduated from a pediatric head injury rehab program, they have many needs at a later date. Those needs include worries about spasticity, the development of post-traumatic epilepsy, cognitive problems, behavior problems, psychiatric issues. They have to worry if they had a weakness on one side or the other, or any type of severe neurologic deficit, joint-related problems, arthritic conditions, bladder and bowel issues, if they had a feeding tube as a consequence of their head injury needs. These all need to be addressed by a good internist and people that are not only versed in these issues, but also have an interest in helping the patient. There, there are new discoveries underway at the present time. Uh, I'm fortunate to practice at a hospital and a medical school that is constantly striving to improve the outcomes of patients with severe head injury. One of these programs involves our research scientists and surgeons, and that is a stem cell program for um, those patients who've had severe head injuries. So it's not, again, for the head injury patient, it's not a stagnant issue. It's one that you, the parent, and the patient should always be looking for new options. What's new out there? What's going on? And try to seek that out if practical. Be aware that there's a lot of us and a lot of our colleagues that are trying to make things better. It's not just survival after the head injury. It's trying to effectively improve the outcomes from these uh, disastrous injuries. Vascular conditions such as ruptured aneurysm, arteriovenous malformation, stroke. Just because you're a child doesn't mean you're immune to these. And intracranial hemorrhage secondary to blood vessel malformations is actually quite common in children. At our institution, we have some of the world's best vascular surgeons and interventional neurosurgeons, where the management of these problems is based on the team concept, and we have a philosophy that these patients, once their vascular condition is taken care of, they still need long-term follow-up. So if you live in a city where you don't have access to care, and you've had to travel somewhere else for your aneurysm or arteriovenous malformation treatment, it's important that you continue that care in the long run with at least a neurologist or maybe a neurosurgeon. I'm not talking about every 3 to 6 months, but once it's been declared that you're cured of your vascular situation, you probably ought to at least stay in contact with a neurospecialist every few years, and maybe even with repeat imaging. A lot of brain conditions, there's not much we can do from a surgical standpoint. There are many malformations of the brain and failures of neurologic development that occur. These are unfortunate. All I can say about this is we are, again, fortunate at big institutions to have neurologists and research scientists that are working daily in the laboratory and with clinical trials to not only discover why some of these things occur, but actually reverse the condition in itself. There's a lot of new therapies being designed to attack the genetic cause of these problems. Some of those are actually quite successful at the present time. So as we go from the pediatric world to the adult world, keep in mind that even though you're 25 and 30 years old, you should still be looking back and see what's going on in the pediatric world. This is especially true in, for instance, patients with a condition called amyotrophic lateral sclerosis or Lou Gehrig's disease. There's a lot being done right now to research why this occurs. That disease has some crossover with spinal cord injury and some other disorders such as spinal muscular atrophy, and another common condition called Charcot-Marie Tooth disease. And all these are neuromuscular or diseases that occur at the spinal cord level that are being investigated very extensively now, especially in the last decade. And in fact, new therapies are coming out almost as we speak to not only put some of these conditions on halt, but maybe even to reverse some of these conditions. Many of you are familiar with the problem of spasticity. The spinal cord injury patient who, or the stroke patient who's sort of recovered part of their neurologic deficit may go on to develop complications secondary to their initial insult, and this results in a spastic condition of the extremities. This may be something easily managed or extensively managed with a good physical therapist, an occupational therapist, but sometimes spasticity can get progressively worse. There's a lot of new things that can be done for this. There's a lot of old things that are quite successful. This requires an orthopedic team, a group of physical therapists, doctors that are competent in tendon release procedures and botulism toxin injections, sometimes spinal cord stimulators, and even the use sometimes of pumps, that a baclofen pump that infuses drugs into the spinal fluid, and then more invasive procedures such as rhizotomies, where we actually cut some of the nerves in the spinal cord to relieve the spasticity. Essentially, patients who've dealt with neurologic conditions, most of you are on the internet all the time, looking, and just be aware that there's a ton of just a ton of neuroscience research being done at many institutions around the country and around the world. It's very important that you continue to stay on the internet, stay on your doctors, ask questions, and be familiar with your particular entity. Be your own advocate and that of your children as you have been. But as you move into the adult world with adult physicians that may not necessarily be familiar with these, it's often the patient's responsibility to sometimes educate their doctors. And if you're coming up against a wall where you're not successful with that, it may be the time to look at second opinions. As we move into a different type of healthcare system in the United States, access to care is probably going to be a real problem for many patients, especially those with chronic conditions. That's why it's imperative that you, again, understand your disease and some of the complications that go along with that disease. As we get older, we develop arthritis. Arthritis may compound scoliosis. If you've got a spastic arm or leg, large joint arthritis is a real problem. If you've already got a peripheral nerve problem, peripheral nerve injury, you don't want to develop uncontrollable diabetes, because that just exacerbates a nerve problem anyway. Those patients that have a predisposition to heart disease, or they have pulmonary problems, those aren't going to get any better if your scoliosis is getting worse. It's important to realize that as a teenager, that last set of spine imaging studies that you had as a result of your scoliosis or your spina bifida might need to be repeated if you have new onset of symptoms. So don't take it as gospel truth that there's no reason to reinvestigate things. Things do change. Those of you with spina bifida, you know that the main thing that we worry about as surgeons and parents is retethered cords, spinal cords. So patient with spina bifida who begins to have difficulty breathing, difficulty of chest pain, if they haven't had a scoliosis follow-up or reassessment, you have to worry that the scoliosis is getting worse, or is it really getting worse, or is their vital capacity in their chest getting worse because their scoliosis is compromising their chest cavity. Those of us that have dealt with spina bifida, we know that syringomyelia can occur and creep up on us slowly. So again, these things require a physician competent in recognizing the potential for these diseases and the way to investigate it. So that's basically a run through of some of the things that I think are important. We'll start taking questions and try to take these in the order that they occurred. This question is from Marissa's mom, and the question is regarding a premature twin who developed hydrocephalus and required a shunt. The question is, do kids with hydrocephalus have anger issues, and is there something better than risperidone now that she's 12? I would say that kids with hydrocephalus and shunt aren't any more particular to some of the psychological issues than other children. In terms of the best drug for that, again, that's what requires a team approach to this. As a neurosurgeon, I would not advocate one drug over another. That's something that we usually, as neurosurgeons, refer to our pediatric neurologist. The question from Arian, can people with hydrocephalus safely travel by air? And the answer to that is yes. There should be no problem in commercial planes in dealing with that. A question from Pam. I'm 55 and had hydrocephalus diagnosed at 1 year of age with a programmable shunt placement. It's still painful along the burr hole and shunt site. Is this typical? My neurosurgeon does not seem to think it is of concern. It does cause headache, however. Sometimes pain at the incision site is not that infrequent. This is something that I think probably will require 2 or 3 visits to the neurosurgeon. But if the shunt's working and the imaging studies show that things are working, I would probably ride this out. A question from Melinda: what implications are there for patients diagnosed with hydrocephalus? I'm not quite sure what you mean implications. I mean, there are a variety of types of hydrocephalus. Most patients diagnosed with hydrocephalus, if it's symptomatic, they need to be investigated as to why that occurred, and to what extent their hydrocephalus is causing them to have symptoms. One of the problems with hydrocephalus is that it causes progressive pressure problems in the brain as the fluid builds up. This can result in a variety of problems, including visual loss, continued headaches, nausea, vomiting, and if left unchecked, can progress to more complex neurologic findings. So it's imperative to be able to classify the hydrocephalus. Not every patient with hydrocephalus necessarily needs a shunt, but it does necessarily need continued follow-up to see if it's getting worse. With that in mind, those patients with hydrocephalus, especially hydrocephalus that is a difficult diagnosis, in other words, trying to figure out why it occurred, those patients probably need at least an MRI scan and evaluation by a neurologist, and maybe even a referral to a neurosurgeon to try and figure out how high their pressure is. A good ophthalmologic examination to look at the retina, see if there's any evidence of a problem we call papilledema, which can be an indicator of pressure inside the head. That complements our evaluation by the neurologist and the neurosurgeon. The next question from Kathy regards her teenage daughter who has a VP shunt, and whether if she gets pregnant someday, the shunt and the tubing in the belly would interfere with the pregnancy. or cause problems? And the answer to that is no. However, a lot of our shunted patients with hydrocephalus are that do get pregnant, we will see them and follow them with the OB-GYN doctors. During the pregnancy, the pregnancy itself probably will not cause occlusion of the shunt, but we need to probably follow them closely with our OB-GYN colleagues should symptoms arise referable to the shunt itself failing. A question from Kathy. I'm an 18-year-old patient who has had over 100 shunt surgeries and has been diagnosed with low pressure hydrocephalus. Now with one shunt set lower in her ventricles and one placed in the cisterna magna at higher pressures, would an adult neurosurgeon know how to treat and deal with this? Also, because of all of her surgeries, will she possibly suffer brain trauma symptoms as she ages? In other words, encephalomalacia. So this is a great example of the problems that people encounter. 100 surgeries and now a complex shunt system that is probably going to require great thought should new problems arise. So yeah, I'd say an adult neurosurgeon is certainly competent to deal with that, but it needs to be an adult neurosurgeon who is willing to deal with that. At our institution, our adult neurosurgeons are great guys, and they can deal with just about anything. Every once in a while, though, it's good to put our heads together and discuss difficult cases. This is why we have 2 or 3 weekly conferences at our institution when we have problems like this come up or patients like this come up. Hopefully, Kathy won't need anything else to be done, but a good game plan in the future is of utmost importance for good outcomes. Another question from Tracy. My daughter is 19 and has a shunt since birth. She is 19 and has had numerous revisions over the past 3 years due to infection and now another possible blockage. Is it common for increased complications in late teens into early adulthood? I don't think the age range has anything to do with the new onset. Other than the fact that if you outgrow your shunt and the shunt's broken, patients usually go. The fortunate thing is most patients don't have shunt problems, but when you do start having shunt-related problems, and especially need for multiple revisions, it seems like there's no end, and you're on a path of continued failure. All I can say is I've been down that path before with my patients. Fortunately, it's unusual, and you just have to stay the course. Often this requires taking shunts out and starting all over again. I'm sure you've been through that before. So this again is why we often advocate having those doctors that are willing to put up with failure. I mean, this is a device that goes into your brain. They don't always work. It's nobody's fault. It's not the doctor's fault. It's not the patient's fault. A lot of patients feel bad that they've done something to cause their shunt to quit working, and that's not true. Our goal as neurosurgeons is to try to get the patient to have the best life they can, and we try to work that out in conjunction with the parents. And then as the child becomes more active, we'll try to give them a little leeway into what they can or can't do. So, you know, I would just say stay the course. Believe me, if you're frustrated, your neurosurgeon is as frustrated as you are with this. And so having good communication is probably the key here, and just recognize that you're not unique from the standpoint of being having so many shunt revisions. There will come that day where you have 1 year of no problems, and then the next year no problems, and then you're starting to smile again. The next question from Arian is when you put a bit of pressure on the shunt in terms of straining or pushing, such as a patient who's constipated, would it cause problems with the shunt? And the answer is more than likely no. Shunts are designed to open and close at certain pressures. There are variations to that theme, but these things are pretty much self-regulating and are designed to work over circumstances such as that. The next question from Kathy: will multiple brain surgeries with encephalomalacia cause problems in the future like the football players are experiencing? So multiple brain surgeries is a totally different problem than the concussive issues. The concussive issues involve diffuse head injury. We're still in the investigative phase of looking at these problems in football players. There's a lot of work being done by the American Association of Neurosurgeons in conjunction with the NFL, and a lot of research being done in this at the present time. We have patients who've had multiple shunt revisions. Yes, you don't want to have that, but you can't correlate number of brain operations with the issue with football players. From Shelley: my son has a VP shunt that drains into his abdomen. Last year the tubing broke. They left the tubing in the abdomen. Is that something that could cause complications at a later date? It's not infrequent that shunts break and we leave tubing in the abdomen. As endoscopic abdominal surgery becomes more frequent, if there's an opportunity to remove the tubing easily, then sometimes we'll do that. At our institution, sometimes if we have complex shunt problems, we'll have our pediatric surgeons do an endoscopic approach into the abdomen. If there's a broken catheter in there, they'll go ahead and retrieve it. But it's not necessary to, it's really not something that we worry too much about. Katie asked a question: if you had an endocrinologist testing for hormones, is that something you should do again once they hit puberty? And what is premature puberty involve? I assume this is regarding a patient who has a neurologic condition. So if an endocrinologist is following the patient, that's something that has to be answered by them. Yes, there are hormonal changes that occur when they hit puberty. If we're talking about hormone conditions related to the pituitary gland or the hypothalamus, which is a special part of the brain that controls hormones, then yes, age changes may be a cause to reassess the patient's endocrine needs. If there are any other questions, feel free to ask. From Arian: my sister had a shunt revision at age 33 after her first shunt was inserted at the age of 7. From time to time, she feels warmth on the side of her head where a shunt is. Then it goes away. Is that typical to be experiencing? I don't know, difficult question. I mean, as we get older, uh, I can't think of any particular reason. Uh, if she had a shunt revision, here we are 26 years later uh, from her first shunt placement. The issue is her skin is thicker. She's probably got a lot more fat underneath the skin. So that shunt revision is probably technically a little bit more difficult than it was when she was a 7-year-old. So there may be a little bit more trauma involved to the soft tissues, a bit more bleeding, a bit more swelling. Sometimes these things take a while to heal up. I'm fortunate as a pediatric neurosurgeon, we're dealing with small children, and shunts are actually pretty simple procedure for us. It's a lot different than operating on an adult patient who is bigger, and it takes a lot more time to expose things in the belly in an adult than in the child. And tunneling the shunt from the head to the belly is a little bit more, it's quite a bit more difficult and technically challenging. Tracy asks, is shunting the best treatment for acquired hydrocephalus from a brain hemorrhage as a result of prematurity? My daughter has a VP shunt. Her surgeon has tried an ETV alone and also a combination of ETV and a lumbar shunt without success. Her surgeon has mentioned trying endoscopic placement of her shunt as he suspects that she has a partial blockage. Is endoscopic placement more risky? Our standard, first of all, premature infants that have hemorrhages in the brain, their chance of developing hydrocephalus is high. Our management scheme is to periodically drain fluid out of the ventricles with a ventricular reservoir. If that fails and they don't resolve their problem, then we move forward with a endoscopic third ventriculostomy and coagulation of the choroid plexus. That procedure has a fairly high failure rate. However, the question often arises, well, why do that if it has a high failure rate? Our thought is that the longer we can prolong the need for a shunt in a premature infant, we've accomplished something. It allows the child to get bigger. It allows them to develop an immune system. It allows the blood that's in there to dissolve, and allows the protein levels in their spinal fluid to improve, making subsequent shunting more successful. Revisiting the issue of endoscopic placement of the shunt is reasonable. Sometimes there are anatomic reasons to think that putting a scope in there and directing the shunt catheter that way is advantageous to ensuring success of the procedure, and I don't disagree with that. Brad asked, in terms of independent living and continued long-term sustainable employment, our neurosurgeons should suggest that an attempt to function in this capacity may be the cause of more frequent pain, headaches, loss of energy, and quality of life. How would one determine if total disability is the best option, considering the longer one continues to be gainfully employed, the less likely one may be considered to have a total disability? Second, is an occupational therapist referral something that should be considered first before that determination? And after the disability determined, in order to attempt to return to a career at some point in the future, or counseling and monitoring of the condition? I guess the question centers around someone who has a neurologic condition but still wants to work and be gainfully employed, it looks like. And I think that's an individual choice. I'm all for people that want to continue to work and be gainfully employed, but if their condition is going to result in them having more problems, sometimes you have to really reassess that as the patient. A good example, patient with back problems. There's a lot of people who have had back surgery. They want to continue to work. It's just not practical for them to do so. They hate to take a disability leave, but on the same token, if they continue to work, and it may exacerbate their condition. So tough question. I think it's more patient, something that the patient himself has to answer than the surgeon. Surgeon needs to be the one to point the way to the patient and say, here's what your likely expectations are, and then you need to make the decision on how to proceed with that. Ben asked, my son is 13 with a VP shunt, which at what age should we transition from pediatric neurosurgeon to adult neurosurgeon? I don't think there's a particular age. Sometimes this is an issue with the institution itself. At the University of Texas, our pediatric neurosurgery group, we continue to follow our patients on an individual basis. However, as we get busier and busier, it's not practical that we can continue to follow. So I think it's just a question of what's available in your local area and who's willing to do what. Kathy asked, how do we help our teenage daughter learn to work with doctors and assess trouble she is having when she deals with memory loss and confusion and doesn't always get details right? And when she isn't feeling good, how will she do this accurately on her own without us someday as an adult? That's a good question, and I think it's this has to do with long-term planning. It's much analogous to those patients dealing with Alzheimer's disease. Spouses that deal with the knowledge that their co-spouse is starting to deteriorate. How can they be that advocate? I think this is something that requires involvement with not only psychologists and therapists, but also church groups and sometimes even attorneys on long-term planning on who can become the patient advocate should something happen to the parents. From Shelley, my son has had tubing replaced. It was draining into the same place as before. It would not drain because of scar tissue. Does the tubing just need to be in the abdomen, create more scar tissue, or would it be from the original placement? At some point, sometimes the peritoneal cavity just cannot function. Those are patients that we often have to change the side of the shunt to either the vascular system or into the chest. I don't know how old your son is, but my personal opinion is I try to avoid the vascular system if possible. I often try to use the chest cavity until sometimes we'll take them out of the belly and allow the belly to heal up. From Ben, my son has had episodes where he exhibited shunt failure. Then the problem would clear up suddenly by the time we got to the hospital. Is it possible for the shunt to drain or clog temporarily or have glitches? Periodic shunt malfunction is something we always discuss as neurosurgeons. Seems reasonable that, yes, that can occur. These are difficult things to assess sometimes. This requires great imaging. It also sometimes requires a look at other things such as seizures. Sometimes it requires a placement of devices to measure their pressure during these timelines to see if the shunt really is working. Sometimes it requires just tapping the shunt. All these are valid things to do. Marissa asks, are there any complications to be aware of as a shunted patient as they grow and get older? Yes, and that's in one of the slides. These include shunt breakage, outgrowth of the shunt, the catheter in the brain changing positions within the ventricle. All these things sometimes requiring shunt revision. What type of doctors should my daughter see on a regular basis? She has a family doctor that sees her every 3 months and neurosurgeons yearly. Sounds like that's probably the thing to do. We see our patients with a shunt on a yearly basis. So that ends our webinar. I would review the slides. We'll be glad to, if you have any questions, you can forward them to us. And thank you for your participation.